All right. Good morning, everyone. Welcome to the Osher Center for Integrative Health Grand Rounds. My name is Andrew Ahn, and I am the lead for the High-Tech Soft Touch Integration Program here at Osher. And through this program, we explore an array of topics from digital health innovation and complex nonlinear systems to even the frontiers of biofield physiology. And in the spirit of exploration, we are honored to welcome Dr. Alessandra Anzolin as today's speaker. Dr. Anzolin will be introducing us to the state-of-art technique known as hyperscanning, which enables the measurement of real-time brain-to-brain connectivity between clinicians and patients during clinical encounters. And Alessandra is a true pioneer in the emerging field, and I'm confident that her insights are both thought-provoking and inspiring. But before we dive in, a few housekeeping items. First, we have a Zoom platform for our grand rounds that allow us to see one another and for a handful for you to ask questions directly during Q&A. But for this to work smoothly, we ask you the following. Please remain on mute during the entire presentation. And if you wish to ask a question, please type in the question in the Q&A feature, and I'll be curating these and we'll present them following Alessandra's lecture. And this meeting will be recorded and later made available on our YouTube channel. So please consider joining our mailing list to keep abreast of when these and other contents are uploaded. Finally, if you wish to request CMEs, email us at this address and to include the following information: full name, degree, institution if applicable. Okay, let me stop this. All right. Now for today's talk, it's my great pleasure to further introduce Dr. Alessandra Anzolin. She's a neuroscientist and faculty member at Spaulding Rehab, where her research masterfully bridges neuroscience and clinical practice. Dr. Anzolin's work focuses on understanding chronic pain by literally observing how two brains communicate in real time. Using the advanced method of hyperscanning, she simultaneously records brain activity from both patients and clinicians as they interact. And this allows her to investigate the dynamic brain-to-brain synchrony that occurs and to probe how the therapeutic alliance forms at the neurological level. Her NIH-funded research addresses critical questions like, can we map the neural mechanisms that foster stronger patient-clinician relationships? And how does empathy materialize in the brain during medical encounters? Dr. Anzolin is truly at the cutting edge of unraveling the art of medicine through a scientific lens, and she draws from her deep expertise in neuroscience, sophisticated signal analysis, and a rich psychosocial perspective. Please join me in welcoming her. Anzolin, Alessandra, you have the floor now.
Yeah. Good morning, everybody, and thank you, Andrew, for your kind introduction. Let me share my screen and slides and be sure that you all can see them. Okay, can you see the slides? Yes, perfect. Okay. All right, so yeah, as Andrew introduced it today, I want to talk a little bit about one of the main topics I've been focused my research on since I moved here to Boston, and I had the pleasure to join the NAPODO lab, which is around the social and psychological aspects of pain. And as we said, in particular, I will talk about the patient-clinician relationship and how we can use advanced neuroimaging techniques to understand even better the role of therapeutic alliance in pain care. So therapeutic alliance is an important and complex construct in clinical care. Probably a lot of you are familiar with this term, but in general, we will refer to the specific bond established between patients and practitioners and built through a mix of verbal and nonverbal communication, in reality as every other type of social interaction. But the reason why we are specifically interested in this one, in this relationship and therapeutic alliance, is that it's been proved that many times how this is a key element of many other therapies and is a key element also of non-pharmacological treatments, which we are also really much interested in. For example, this is a study from 2013 from Paulo Ferreira and his colleagues, in which they looked at spinal manipulation and exercise on a population of chronic patients with the chronic low back pain. And they showed that the patient-clinician therapeutic alliance was a predictor and a moderator of pain, together with other outcome. And then they already at the time, they suggested that boosting and improving therapeutic alliance could improve the efficacy of the intervention itself. And this is not only true for pain, because we know that specifically the way we interact with the world around us and our practitioner can shape the way we perceive and feel pain, but also other fields of medical care. So here, for example, there is a meta-analysis from 2015 on psychotherapy that shows how contextual factors such as empathy and therapeutic alliance presented the largest effect size in terms of clinical outcomes. And this is compared to specific ingredients. So they concluded that these common factors, non-specific factors, were actually the most important for treatment efficacy. On top of this, understanding how to improve therapeutic alliance and patient satisfaction is not only relevant for the patients, but is also important for the clinicians. For example, this paper published in 2020 from Maserotti and his colleagues showed how better communication skills and having a better communication plan for the clinical intake is associated with reduced risk of clinicians' burnout, which we know being a major problem in healthcare nowadays. So in the US, almost 50% of medical doctors experience burnout. And then other study also associated a strong therapeutic alliance with higher job engagement for clinicians and increased accuracy in diagnosis, probably because of more open communications and exchange of information related with the patient's problems. So now we know that a therapeutic alliance is important. We understand why. We understand it's important for both patients and clinicians, but there is still a lot that we need to understand in terms of how that works. And in particular, we ask, how do we study the brain mechanisms underpinning this patient-clinician interaction? So this question was asked a while ago, and it applies to any social interaction. So if we look at this illustration, we have subject 1 as a patient and subject 2 as a clinician, but this could be any interactive diet. And what we observe here, I tried to represent is that while interacting, both individuals are constantly acting, but also reacting to each other's based on verbal and nonverbal cues. And also they come into this interaction with their own history, needs, motives, expectations, and all of this can be updated over time depending on the other's behavior. So the vast majority of existing research on patient-clinician interaction investigated the brain mechanisms on only one of the two subjects, which usually is the patients, of course. So the patient is the system investigated, and everything else, including the clinician, is an input to the system. This model is absolutely valid and gave us a lot of insights in the study of these interactions, but we cannot neglect that we are only looking in this way at half of the system. So in order to fully capture the dynamic of the interactive diet, we need to consider this whole loop that we represented here as the system. So we need to have both participants included in the model. And in order to do so, we need what is called the two-person neuroscience, which is based basically on 2 points. One of them is hyperscanning, which is this simultaneous acquisition of brain data, but more in general, I would say neurophysiological data from 2 or multiple people involved in interaction. And second, multi-subject analysis. So once we acquire those data from both subjects simultaneously, we also need to be able to analyze them together so that they can inform each other and we can understand what in one data set is explained by the other. So EEG, like in hyperscanning, in this example, we will see specifically electroencephalography, but in general, hyperscanning is a relatively novel neuroimaging technique, but it's been used more and more in the past 10 years to target a lot of different social interaction. So here I reported some of the examples. We have two people juggling, we have two people gaming while using a brain-computer interface. We have pilot and co-pilot, musicians. Music is a great example to develop hyperscanning methods because it really targets nonverbal communication, parents and child, but still we have a very little usage of this technique to explore the patient-clinician interaction. So going back to our original questions, how do we look at these brain mechanisms behind the therapeutic alliance? The take-home message is that real social interactions can only truly be understood by studying both systems together and in an ecologically valid context. But what do we think is happening in the brain during a clinical encounter? So the principle we are targeting is rooted into the theory of the mirror neurons. Mirror neurons are a type of nerve cells that was first found in the premotor cortex. And what is interesting about those neurons is that they fire both when we are performing an action and we are witness others performing the same action. Now, today we know that this mirror system does not only work with motor tasks, but there is a whole social mirroring circuitry that helps us creating representation in our brain of body sensations and emotions, which might be also at the basis of how empathy works. So this circuitry involves primary somatosensory areas, as well as areas involved in empathy and mentalizing. So some of them are represented here. We have ventrolateral prefrontal cortex. We have temporoparietal junction, or TPJ, which will come back a lot in this presentation, and anterior insula. So going back to our patient-clinician interaction, what is our hypothesis? We hypothesized that the degree to which clinician social mirror systems reflects patient brain response to clinically relevant stimuli, plays a clinical role in nonverbal communication. Second is linked with perception of therapeutic alliance by the patients and is related with the clinical effectiveness, and could be measured as a brain concordance using hyperscanning. Here I reported specifically fMRI and EEG hyperscanning because in our studies, we tried to employ both of them. So when we say fMRI, we refer to functional magnetic resonance. EEG is electroencephalography. Those are two different neuroimaging techniques. And the reason why we decided to do both is not only to make our life very complicated, but is also because they both come with different advantages. So magnetic resonance, for example, offers a very high spatial resolution, so provides indicators of subcortical concordance. We can understand very well what areas in the cortex and subcortical are involved in those processes. While EEG comes with high ecological validity, you can already see in this illustration, people are sitting face to face in front of each other, and brings the possibility to target very fast dynamics in the brain-to-brain connectivity that are happening while two individuals are interacting. And this is because EEG has a very high temporal resolution. So not only we are trying to preserve the ecological validity of the experiment, but in our study, we also work with the real clinical diets. In particular, patients are individuals with chronic pain, which for some studies are chronic low back pain, and for other is fibromyalgia, which we believe also helps us in generalize our results. Rather than apply them to one specific population. And when we talk about clinicians, we are talking about licensed acupuncturists who provide a very specific treatment depending on the clinical population. Now, before we dig into some of the results we found, here is an overview of the studies we conducted. If we look at studies 1, 2, and 3, and we are still conducting, if you look at study number 4. As you can see, we started with the simplest design. We wanted to compare clinical diets who had the opportunity to see each other and interact before the hyperscan session to clinical diets who never saw each other before the scan. And after we answered this first question, then we started introducing more complex elements. For example, in study 2 and 3, we tried to manipulate the clinical context In study 2 and 4, we introduced a longitudinal intervention to see if therapeutic alliance evolves over time. And finally, you can see from those illustrations how in study 1 and 2, we used the fMRI hyperscanning. In study 3, we moved towards EEG hyperscanning. And in study 4, we are doing both EEG and fMRI hyperscanning, which we are really excited about. Okay, so we can start from study 1. This study was led by Dr. Dan Michael Ellingsen, who is now an associate professor at the University of Oslo in Norway, and involves fibromyalgia patients and acupuncturists. Here, patients were randomized to either have a clinical intake with their provider and then go together into the fMRI hyperscan portion of the experiment, or to go straight to the fMRI session without any previous encounter. And this was our control condition. So we call them interaction versus no interaction. And when the clinical intake happened, we asked the acupuncturists to perform the intake in a similar manner to their own practice so that we could have a natural variability in the style of the interaction. Here you can see a picture and an illustration of our very complicated fMRI setup. We have 2 3 Tesla scanners synchronized by an external trigger. We use fMRI compatible cameras to allow the patient and the clinician to see each other while they are in different scanners, and use that part of the nonverbal communication that relies on facial expressions. During the hyperscan part, clinical dyads performed and evoked pain tasks, which will come back a lot in all the other studies too. So our patients experienced evoked pain pressure to elicit pain, which was delivered by inflated cuff around their low left leg. And at the same time, we used 2 needles placed on the left knee right above the cuff to treat this evoked pain. So basically, we connected the 2 electrodes to the 2 needles, so a very low current could flow through the needles when activated by the acupuncturist. And the acupuncturist can activate this electroacupuncture just using a button box while in another room and in another scanner. So this is one of the main reasons why we decided to employ acupuncture in this study, which is that there are not many other treatment that can be delivered remotely while the clinicians is actually in another room in another scanner by just clicking on a button. So here is, so this is a more detailed description of the task. First, we have an anticipation cue here, where the frame around the screen and around the face of the patient and the clinician changes color, and it becomes green if during the current trial the evoked cuff pain will be treated by the acupuncturist through electroacupuncture, and red if the clinician can only watch the patient receiving pain but cannot treat the pain they're receiving. The painful stimulation is 10 seconds long and gets repeated 12 times. And each cuff pressure is calibrated to evoke moderate pain, which is equal to like a 40 on a scale between 0 and 100, where 0 is no pain and 40 is the worst imaginable pain. And then at the end of each trial, the patient and the clinician are both asked to rate the pain intensity. And in particular, we asked the patient how painful was the cuff, and to the clinician how painful do they think the cuff pain was for the patient. So to rate their vicarious pain. So our main behavioral outcome in the study was the therapeutic alliance, and we used a scale called CARE, which is consultation and relation empathy, to measure it. And it asks a series of questions around whether or not the clinician was interested in the patient, was actively listening, was interested in the patient as a whole person. And we have 2 versions of this questionnaire, one for the patient and one for the clinicians. So they both filled this questionnaire. So in agreement with what we expected, both patients and clinicians reported higher care score during the clinical intake and during the fMRI following the intake, which are the dark color and the second darkest color, compared to the fMRI without intake, which is the lightest color in this representation. We also observed a significant reduction in pain intensity as rated by the patient during the treatment trials versus no treatment trials. And even more interesting, we saw the same reduction was found in terms of vicarious pain as rated by the acupuncturist. And keep in mind that the pressure delivered is always the same and that the acupuncturist cannot see the patient's rating. So when we looked at the difference between a treatment and no treatment, the trials in terms of pain intensity and vicarious pain, so we extracted this delta, we found a significant correlation between this measure extracted for patients, which we interpret as analgesia, and clinicians, which we interpret as perception of treatment efficacy. So in other words, the clinician perception of the patient's pain and analgesia during treatment was perceived probably through a series of nonverbal cue of what the patient was experiencing. And then in order to understand a little more about this specific aspect, we looked at the facial expressions recorded while patient and clinician were performing the task in the scanner. So we use an open source AI algorithm called Affectiva just to investigate this facial mirroring in the patient and clinician interaction. And we extracted those like global value of facial mirroring, facial expression mirroring, and we found very interesting results. In fact, not only we found that the clinician facial expression mirrors that of the patient, but it also correlates with the therapeutic alliance and analgesia. In particular, greater mirroring was higher, was linked with higher therapeutic alliance and higher analgesia as rated by the patient. So next, we looked into the brain and we asked if there are specific, like similar mirroring effects happening in the brain during therapeutic alliance. So we performed a multi-subject analysis and we had to define a new brain concordance measure based on trial-by-trial dynamic changes in patient and clinician activity, which means that we looked at changes across trials in the patients and clinicians' brain activation. And what we did was to identify those areas in the clinician brain whose activity is higher when it's high in the patient and low when it's low in the patient, which is why we consider this measure of dynamic concordance is not because it's time varying, but it's because it's extracted based on variability across trials. And this measure showed a higher brain concordance between patient and clinicians following a clinical intake compared to the clinical diet scan without an encounter before. These brain concordance, interestingly, involved those social mirror circuitry areas that we introduced before, such as the ventrolateral prefrontal cortex, temporoparietal junction of TPJ, anterior insula, and some others. But what is really interesting is that when we tried to link these measures of brain concordance for each one of those areas, we only found a connection with therapeutic alliance and with the pain analgesia, actually not therapeutic alliance, when we consider the connection between right TPJ in the patient and right TPJ in the clinician. So in other words, only when TPJ activity in the clinician is linked to TPJ activity in the patient, and we have this high concordance, that's when we have eye pain relief. So this first Hyperscan study taught us a lot. In summary, we discovered that therapeutic alliance and TPJ to TPJ concordance are enhanced by the patient-clinician interaction, and also that greater TPJ to TPJ concordance and facial expressions mirroring are associated with greater pain analgesia. From here, with this knowledge, we engaged in study 2 and 3 with this idea of introducing a manipulation of the clinical context. So we want to replace an interaction versus non-interaction group with two groups, both interacting but with different clinical styles. So we start with study 2, which is an fMRI longitudinal study which will allow us to understand also if therapeutic alliance is formed over time. So that's what we did in our second study, who was led my dear friend and colleague, Dr. Arvina Gral, who has been involved in all these studies with me since the very beginning. And this is a timeline of this second experiment. So following a baseline hyperscanning visit, patients were randomized to receive a 3-week acupuncture treatment with either an augmented or a limited clinical context. And after that, we asked both patient and clinician to come back for a second fMRI hyperscanning visit to see if we can detect the specific changes happening in the brain while they are performing a pain treatment task. How did we manipulate the interaction style? To do that, we employed a model that was introduced by one of our colleagues and my mentor, Ted Kapchak, in which we trained our clinician to perform either an augmented or a limited interaction style. In particular, in the augmented group, the clinician can have a long and personal conversation with active listening and the personalized contact, while in the limited group, clinicians are instructed to have a more neutral and impersonal interaction. So we define the augmented, very much patient-centered, and the limited business-centered interaction. And this model was already used in Ted's paper from 2008, and he showed that patients with irritable bowel syndrome who had an augmented intake with their therapist reported an improvement in symptom severity, which was almost a double compared to those who had a limited interaction and compared to a waitlist. Showing that not only, once again, the importance of therapeutic alliance, but also the validity of the model we're about to use. So we already said we have a fibromyalgia patient, licensed acupuncturist, and this is the protocol used by the acupuncturist for fibromyalgia. So in terms of perceived quality of the patient-clinician interaction, what we found is a much higher therapeutic alliance in the augmented group compared to the limited, as reported by the patients and both also the clinicians, actually. And here we use the same measure we introduced before, which is the CARE score. What we didn't see is a significant change over time. So when we compare session 1, 3, and C, not much is changing after that. This might be partially because of the ceiling effect. The augmented group basically almost maximize, use the maximum scores for the scale since treatment 1, but it could also suggest the important, highlight the importance of the first encounter between the patient and the clinician. Similar results were found for perceived warmth here, while a little different is for perceived competence. So basically only during, here we didn't see any difference between groups until the very last treatment, which is like session 6. And only here the competence was rated as higher by the patients in the augmented group compared to the limited one. So overall, those results confirmed the successful manipulation of the interaction and highlighted the importance of the first visit. And when we look at the clinical outcomes, we found that after 3 weeks of acupuncture, pain relief was significant in both groups, limited and augmented. And also that was stable across sessions, even though I didn't report that detail in this slide. So while we discovered that the clinical context did not affect directly pain intensity and severity, we also discovered that it affected very important aspects of the patient's experience during their clinical journey. So in particular, we observed like in pain catastrophizing, and which is the affective dimension of pain, in the willingness to continue to see their clinicians and expected pain relief in future treatment. They all significantly improved in the augmented group, but not in the limited group, which was really interesting. Now, in order to understand if there are specific brain-to-brain or brain concordance mechanisms associated with those very interesting longitudinal outcomes, we are analyzing brain data. This collection was completed a few months ago, so we are now in the middle to develop our pipeline, and we will be hopefully able to answer to some of those questions soon. So brain analysis ongoing. And so we can conclude for this second study that not only we successfully were able to manipulate the clinical context in these two groups, which is a very good tool for us to understand more about therapeutic alliance, but also that following a 3-week acupuncture treatment with augmented interaction style, patients reported reduced pain catastrophizing and higher adherence to treatment compared to the limited group. And this brings us to study 3, which is our first EEG hyperscanning study, which I'm really excited about because my main background is in EEG hyperscanning. And this study gave us the possibility to confirm the results that we talked about so far in other clinical population, because in this case, we have patients with chronic low back pain, and to look into new brain-to-brain measures. So we continue to explore this patient-clinician interaction using a more naturalistic experimental setup. In particular, we recruited 37 patients with low back pain, and we paired them with 10 acupuncturists. So each one of them was paired with more than one patient, because it's really hard to recruit. It's harder to recruit acupuncturists compared to patients. But after data quality assessment, we have our final sample of 34 unique clinical diets. This is a short clip showing our very unique setup for EEG hyperscanning here at Spalding Rehabilitation Hospital in some salient moment of the patient-clinician experiment. So we start placing the EEG net with 64 channels, water-based, on the patient's and clinician's head. We have an amazing team working simultaneously, so we can do the setup on both participants at the same time. So the setup really takes very little time. We need to work on single electrodes, as you just saw, to ensure maximum contact with the skin and high quality of the brain signal. We also record other physiological measures. You just saw 2 electrodes to record galvanic skin conductance, and the ECG electrodes for cardiac signals, as well as the cameras for recording facial expressions. And then all the experimenters leave the room, and as you can see here, we leave the clinical intake happen, interfere very minimally with their ecological validity, and giving them the privacy that they need. So the patient and the clinician are sitting face to face, preserving every aspect of nonverbal communication. And similarly to what we saw in the previous design, the clinicians performed either an augmented or a limited intake. Next to Hyperscan room, here is what we can see is an observation room, and the 2 environments are divided by a one-way mirror so that we can see and monitor the interaction while they cannot see us. And at the same time, we can monitor data quality on those screens and the video recording for future facial expression analysis. Following the intake, we recorded a short resting state, and then we proposed again the same evoked pain task we already saw in study 1 and 2. So just to refresh our memory, the patient experiences evoked pain delivered by inflating a cuff around their lower left leg, and we use 2 needles placed on the left knee right above the cuff to treat their evoked pain. So we define 2 experimental conditions, same as before: treatment and no treatment, depending on whether or not the clinician does treat the cuff pain using electroacupuncture. And it activates again using just like pushing a button. Then we remove the net and sensor and everything, and the patients receive an actual intervention, which is acupuncture for low back pain. Now, looking at the clinical and behavioral outcomes, study 3 confirmed a lot of results we already saw in study 2, but this time on patients with low back pain. First of all, Therapeutic Alliance still measured using a CARE score, and perceived warmth was both rated as significantly higher by the patients in the augmented group compared to patients in the limited group, providing again a proof of successful manipulation of the clinical context. No difference was seen for competence, because we only have 1 intervention here. Then low back pain was rated before and after the acupuncture treatment. Didn't report here the box plot, but was significantly lower in both groups, confirming again no differences in pain relief. And then we observed again increased adherence to treatment in the augmented group compared to the limited group, which is reported as higher willingness to continue seeing their clinician, as well as higher pain relief expected for future acupuncture treatments. And then we used another scale called the positive and negative affect schedule as a measure of their mood. And so what we found was a decrease in negative affect in the patients following augmented interaction, which we did not see following a limited interaction. So once again, no direct effect on pain relief, but very strong effect on other dimension of the clinical encounter. So what is happening in the brain in the meantime, and especially how can we estimate brain-to-brain connectivity between patients and clinicians now that we have access to EEG data? EEG come with one main signature, which is time resolution. So the time resolution of the EEG is of the order of milliseconds, so really, really fast. And this translates into three main things. One is that we can look at brain concordance within trials rather than use trials as repetitions. So now we can compare treatment versus no treatment conditions. We can look at the direction of the connections, very important. We can use causality-based measures to distinguish between the information flow directed from the patient to the clinician and the clinician to the patient. In this illustration, they are represented in green and blue. And we can look at brain rhythms. So EEG is characterized by specific frequency bands. From the lowest to the fastest, they are delta, theta, alpha, beta, and gamma. And here we will focus specifically on alpha and theta, as those two rhythms were associated already in the past with pain perception and higher cognitive processes involved in empathy and cooperation. What EEG does not have is a good spatial resolution. But what we did to overcome this limitation is to apply linear inverse algorithms to perform source localization and still have results that are comparable with what we obtained in our fMRI studies. So starting from 64 channels, sensors on the scope, we localized 17 cortical areas based on the area we observed in our previous studies. This is one way to visualize patient-clinician interbrain networks, where each one of those arrows that we see here is a statistically significant causal link between brain regions in the patient and another brain region in the clinician. So each one of those connections is an arrow because it does have a direction, as we already said, can be directed from the patient to the clinician or vice versa. And also, even if it's not visible in this representation, each one of those connections comes with a number, which is their strength or intensity. So is a measure of how much information is carried by these signals. Of course, it's almost impossible to quantify the main results just relying on visual inspection of these maps. There is a lot going on. So what we usually do is extracting simple measures in which either we count the amount of connections exchanged between the two brains. So we talk about interdegree or interdensity. Or we have interstrength, which also consider that number we talked about before. So the strength of each connection, or like the strength of the overall information flow. So when we extract the interdegree and separate that for like a clinician to patient versus patient to clinician, we notice that the augmented group showed a higher number of patient to clinician interbrain connections compared to the limited group. And then when we introduce the factor treatment versus no treatment, we discover that not only the patient to clinician brain-to-brain connectivity is directionally modulated by the clinical context, but also by the presence of the treatment during the painful stimulation. So from the clinician to the patient, we see so this first column, we see a higher number of interbrain connection during the no treatment condition, which is the first row, suggesting that social mirroring and empathy are driven by the clinician when they experience empathy for pain. So when they're not treating the pain, but they're watching the patient receiving pain. On the opposite direction, the number of interbrain connection directed from the patient to the clinician is higher in the treatment condition, suggesting that higher social mirroring led by the patient this time happens when they know that the clinician is actively treating their pain. So maybe they're using nonverbal cue to communicate how much in pain they are. So importantly, this beautiful brain-to-brain dialogue only exists and was only visible for us in the augmented group. In fact, when we extracted the same connectivity maps for the limited one, if we look at the patient-to-clinician connectivity network, these basically almost disappears. Given that there's a big difference in the density of patient-to-clinician interbrain network during treatment versus no treatment trials, we decided to extract this measure as interbrain density and interbrain strength, and to see if those indices are linked with the therapeutic alliance or pain outcomes. And what we found was a significant correlation between both those concordance measure and evoked pain analgesia. So higher interbrain density, the higher interbrain strength, the higher is the perceived pain analgesia during treatment trials. The last question we asked was whether specific brain regions are playing a role in this brain-to-brain information flow. And so in this visualization, each brain region extract based on our previous fMRI study is represented by a sphere where color and size both code for the degree of involvement of that specific area in the brain-to-brain network. So from the observation of those maps, we can already see that in the augmented group, TPJ is a significantly more involved as a hub in this patient-to-clinician information flow compared to the limited group. And additional, like there are other areas that are modulated, like differently active or involved in the two groups. But when we try to make the degree of each region, when I say degree, means the degree of involvement in this interbrain connectivity network, only TPJ degree, this time bilateral, was correlated with the ratings of therapeutic alliance. We also observed a trend for ventrolateral prefrontal cortex, but this did not survive multiple comparison correction. So from this third study, we understood even more about these mechanisms. We discovered that brain-to-brain connectivity is directionally modulated by the clinical context and treatment of pain, that the patient-to-clinician information flow is enhanced by following an augmented interaction, and that TPJ brain-to-brain connectivity is correlated with measures of therapeutic alliance. So clearly, temporal-parietal junction plays a key role in the patient-clinician interaction. We saw this in study 1 with fibromyalgia patients and in study 3 with chronic low back pain patients. So now one spontaneous questions after all of this for us was what aspect of therapeutic alliance are decoded by the activity of this area. So in this meta-analysis from 2012, we found some of the answers. Here, they collected several papers looking at brain responses to empathy and theory of mind. And when they looked at this grand average map, they both reported strong activations in temporal-parietal junction. But what is interesting is that when they contrasted those two maps, the theory of mind versus empathy, they discovered that TPJ is much more involved in theory of mind compared to empathy. So what is the theory of mind or mentalizing? Theory of mind is a cognitive process by which we are able to put ourselves in others' shoes. Basically, it helps us understand what other people might be thinking or feeling, and obviously this helps us to better connect with them and communicate with them. So our next challenging question is, can we come up with a theory of mind training for chronic pain patients in order to increase the therapeutic alliance, boost this patient-clinician TPJ concordance, and ultimately improve clinical pain outcomes? And this is what brought us to start our fourth study, which hopefully will soon answer all those questions. And it relies on a novel theory of mind training for patients with fibromyalgia, both EEG and fMRI hyperscanning, which is really important because we will have for the first time both measurement from the same clinical diets. And we kept the longitudinal aspect of acupuncture treatment following the theory of mind training. So in this case, we have two clinicians involved in the study. One is a pain psychologist providing the cognitive training, and the other one is the acupuncturist providing treatment for pain. This is our randomized longitudinal trial with a total of 14 visits. We start with a consent visit, followed by two baseline visits, one for EEG hyperscanning and one with fMRI hyperscanning. We don't do them simultaneously, but we wanted to keep the EEG in the ecological, like the ecological context or like set up for the EEG. So we do that in 2 different days. Then patients are randomized to experience either a theory of mind training or an attention-matched education control intervention. And this is for 4 weeks. And here is where they meet their pain psychologist. After that, we have a second EEG hyperscanning, so plus the theory of mind training. And as part of the EEG hyperscanning visit, they receive their first clinical intake with their acupuncturist and their first acupuncture treatment. And this allows hopefully for the training to be reinforced as we encourage the patients to practice their new theory of mind skills. After other 5 sessions of acupuncturist over the course of 3 weeks, we have one last imaging visit with fMRI hyperscanning, and we also have a last clinical and behavioral assessment. So we are still blinded, of course, to the randomization for this clinical trial. So we only acquired 16 out of the 80 diets that we are hoping to collect. But at the same time, in parallel, we are collecting data from a smaller study in which we enrolled patients with low back pain, which the sample is almost completed, is like 11 out of 15. We don't have a control groups here, but we can start the assessment of our new theory of mind training developed by my amazing team, and in particular by Dr. Arvina Gral and Rob Edwards and Jolene Yamin. The primary focus of our theory of mind training is to improve patients' ability to understand others' mental states, especially given that multiple studies have shown in the past that patients with chronic pain have theory of mind deficits. So the first section is a mix of mindfulness training, exercise to learn how to recognize their own thoughts and others' thoughts, and then it builds upon that, and it includes interactive dialogue, story-based mentalizing, and sensory motor synchronization task, and so on. And as a control condition, we have the education training, which simply provides information about the nature and presumed cause of fibromyalgia. And this was a protocol already developed and validated in one of our previous studies as a control for cognitive behavioral therapy. So one question we get a lot is why we're focusing on training patients rather than clinicians, or as if we're blaming them for like poor clinical encounters. This is not our point of view. What we are doing here is just trying to add an additional layer. We fully support all the training programs that help clinicians build empathy and communication skills. So we're just trying to provide patients with the tools to strengthen their own theory of mind skills, their ability to understand what others might be thinking or feeling, and especially for people with chronic pain conditions or chronic conditions in general, who often see many different providers. This can really help them navigate the system with more confidence. So this is about giving patients more agency and help them feeling like more connected and understood, which ultimately we hope is going to strengthen their therapeutic alliance and all other outcomes related to that. Some very preliminary results from our pilot study. Following the theory of mind training, we saw that the quality of the patient-clinician interaction as perceived by the patient was improved, as it showed by this score called PEPI, which it means perceived efficacy in patient-physician interaction, is a validated questionnaire. And then we have higher perceived intention to treat as rated by the patient and emotional closeness between patients and clinicians. Also, pain intensity was significantly reduced compared to baseline, as well as pain severity in the past day and in the previous 7 days, where no acupuncture treatment was provided. So already, like just after the theory of mind training, there was a better management of pain. And then following the acupuncture treatment, we also observed this decreased low back pain as reported by the patients. And interestingly enough, this pain relief was correlated with the changes in this measure we just introduced, the PAPI score, which means that improved perception of patient-physician interaction was linked with bigger reduction in clinical pain. So this is very promising. Is thanks to my postdoc, Juni Dawn, that we were able to look into these results, and she's now working on some of the brain data acquired during the EEG Hyperscanning session. And I want to close with some of the feedback we got from our patients, which even more make us excited about this project and believe in the potentials behind this training. When we asked them, how would you briefly describe this training to other patients with fibromyalgia? One of them answered, focus on understanding other perspectives and communicating for yourself more effectively, confidently, and assertively in your personal relationship and with other medical practitioners. Another said, the training is informative and helps advocate for yourself and makes yourself a priority. And to the question, can you think of any example in your everyday life where you can apply the skills you learned? One answered, I have not had the opportunity to use the skills acquired. However, I intend to. I only expected to get acupuncture treatment, and instead I got a valuable insight into navigating the medical system. And yes, moving forward will help me a whole lot. And another one says talking to specialists. So I just wanted to report some of them. There is like so many very beautiful answers we got, but this is to highlight how what we're providing is a tool that can be applied to the patient-clinician interaction to help them navigate the medical system, but also hopefully can help them improve and give them back some of the social skills to restore their social life even outside the medical context. So very briefly, in summary, in this talk, we understood how the understanding brain circuitry supporting the patient-clinician interaction requires two-person neuroscience. We understood the importance of hyperscanning. We understood the differences between EEG and fMRI hyperscanning. We discovered that the clinical context does not modulate analgesia, but other important aspects of patients in clinical experience, such as pain catastrophizing, mood, adherence to treatment. That TPJ is a key brain region in the brain mechanisms behind patient-clinician interaction and correlates with pain analgesia and therapeutic alliance. And the theory of mind is a cognitive construct that can be enhanced by training and could ultimately improve the clinical outcomes. I cannot thank enough all the collaborators. None of this incredible research would be possible without an incredible multidisciplinary team and the support of different institutions and NIH. And my mentors, Vitaly Naprov and Ted Kupchak. And thank you all for your attention. I'm now happy to answer to any question or curiosity you might have.
Amazing, Ale. Thank you so much. That was a tour de force. I don't know how you do these types of studies because it's so complex. It's great. There's a lot of questions here. I don't think we'll have time to go through everything, but I just have a question, Ale, about your thoughts on the TPJ. Like, why is it so significant when it comes to social mirroring, and how does it relate to the pain network, in your opinion? Why is it that seems to be the single site that seems to be activated when it comes to all these different types of patient-clinician interactions?
Yeah, let me stop sharing this. Okay. So yeah, that's a very good question. And there is still a lot we are trying to understand about this brain area. But the reason why we are really excited about the results around the temporal parietal junction is that it basically sits at the convergence to many different dimensions, right? So we saw that as is being already observed in that social mirroring circuitry in which like people are mirroring other people's emotions. We understand how it's true that is in common between empathy, theory of mind, mentalizing, several different cognitive processing happening when we are trying to understand someone else. But it's a specific of mentalizing. And this brings us to talking about pain, because not only I'm able to understand someone's feelings and thoughts, but I also am able to mirror probably and understand and create my own representation of how that person is perceiving pain, and in both directions, when he's in pain and when there is any type of pain relief. So probably is the equivalent of what we observed in facial mirroring is this like brain mirroring and brain to brain dialogue that helps in this whole nonverbal communication, and is at the basis of both therapeutic alliance and translated to therapeutic efficacy.
Hmm. And how much of that, Alessandra, do you think is that related to like visual cues? You know, because if you're mirroring facial expressions, but there are questions in the chat here in terms of the effect of the clinician's voice or even touch. You know, how do you, is that something, do you think, if you just purely did voice or even just did touch, you know, blind someone, even, you know, put a to ear to block hearing, do you think that same region is affected, or do you think the therapeutic alliance will also exist in the same way?
I do believe that the therapeutic alliance would exist in the same way during different types of interaction. But I would say that the results I presented today are very specific of nonverbal communication, just because during the pain task, which is what we acquire, like is like during the pain task is where we acquire the data and analyze the data. Basically, the patient and the clinician are not communicating verbally, so the clinician is not speaking. And there is no touch allowed because the electroacupuncture is delivered just pushing a button. And so, like I would say, we are starting from a condition in which actually we have none of these elements that you brought up, so speaking and touch. But we are very much interested in that. It's just a little more complicated to study, so we are going to increasingly add different components. During the EEG experiment, we do acquire the data also during the intake, so not only during the task, but while people are actually talking, and there are moments in which the clinician is touching the patient to assess the several symptoms. So in that case, that analysis will answer in more specific detail to those questions. So there are, for example, vocal patterns that elicit specific brain-to-brain connections. Are there specific moments in the encounter, the beginning versus the end, specific words, a specific tone of voice that trigger all of this? So we are going to try to analyze the brain data simultaneously with the video and the voice recording to try to answer in a more specific way to these answers.
Yeah, amazing. And I look forward to also, I guess you got some heart rate data. You also got, you know, skin conductance. So it'd be interesting to see how that plays also in the patient alliance as well.
Yeah. No,
Yeah.
absolutely. We are trying to, like, that's one of our main goal for the future in terms of methodological developments is to also introduce this autonomic concordance measure. There is nothing that is very reliable right now other than trying to correlate those measures between patients and clinicians, but we want to try to understand how eventually there is a mirroring also in terms of how like our physiological system responds. So we're working on extracting some of those measures, calling, for example, mutual information exchange in terms of cardiac time series and skin conductance and respiration. And try also to connect them with processes like interoception and other constructs that could help with disentangling why specific people like mirror or like are able to perceive the others' physical state more than others.
Sounds like tons of papers are we're going to see come our way from your group. So that's great. And there are a lot of
Thank
questions
you.
that we couldn't get to. Is it okay if they reach out to you to answer some of these?
Absolutely,
Okay,
absolutely.
great.
I think that my email is in the first slide, so yes,
Yeah,
please reach out, and I would be happy to talk about anything.
great. Well, thank you so much, Ali. That was an excellent talk. Thank you.
Thank you,
But
Andrew.
yeah, before everyone signs off, there are just a few important first announcements. First, mark your calendar for the Tai Chi Qigong Conference on April 30th to May 1st, 2026, being held at Harvard Medical School. This conference will strongly emphasize mechanisms and physiology of Tai Chi and Qigong, when we have an amazing line of speakers, so please do check it out. Also, if you look forward to similarly just awesome, very intriguing talks, please be sure to attend the next Osher Grand Rounds on November 4th. Dr. Rubal Patel will be speaking about the tapping into the sounds of health. Dr. Patel is a professor at Northeastern who specializes in speech science, human-computer interaction, AI. And on December 2nd, Andrew Weil needs no introduction, will be our inaugural Logan or our Logan Integrative Medicine speaker this December. Also on October 20th, on 2025 at 2:40 to 3:45, there's going to be a co-sponsored talk on the wave of meditation research given by Matthew Satchett. I don't exactly have that on a slide, but be sure to pay attention to our website regarding that announcement. And yeah, so we do our best to make this great work available to all. So please consider supporting us and help us continue this work and use this QR code to get onto our website. Thank you all for joining us today. And thank you, Ali, for a great talk. Looking forward to seeing your group do so much more. Thank you.